to talk on his very favorite topic, and that is IFIS.
Thank you. Yeah. So I guess this speaker screen. Yeah. So thank you very much, Gaurav, Namrata, and AIOS for this very kind invitation. So I'm going to be speaking on understanding and strategizing in IFIS. I'm Suvin Bhattacharjee, and I do have a financial interest in the BHEX People Expander. I acknowledge the contribution of Dr. Deepak Magur and Dr. Ajay Paul for their videos. Now, in the operation theater or in the OPD, what is a safe preoperative pupil size to eliminate the risk of IFIS? This is a paper by Alessandro Casticchio and co-workers, which they concluded that for a pupil 7 millimeters or smaller, the risk of IFIS existed regardless of alpha blocker use. Now, in India, the risk is apparently higher, and hypertension is a definitely important risk factor. Now, that initially we started with alpha blockers, but then the list has really become long, and no amount of history taking can really prevent surprises, with hypertension being there on the list. And intraoperative myosis is really an unpredictable factor, so we must come to terms with that. That's the classic grading of IFIS, but what's more important is the non-dilating pupil, the floppy iris, and the intraoperative myosis. Those are the complications, which are mostly because of the iris incarceration in the incision or in the phaco tip, and all of this can be avoided or minimized by using a good strategy. The general principles would be to use long and tight incisions, slow hydrodissection, intracameral phenylephrine or adrenaline, and judicious use of viscoelastics, and of course, low IA parameters. Now, preoperative NSAIDs, there is no evidence that they augment pupil dilatation alone, but they do prevent intraoperative or reduce surgically induced myosis by contact with the iris. Now, Chang and Campbell in 2005 introduced us to this wonderful term of IFIS. What they highlighted, and probably lots of us missed to read, is unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it, which suggests that basically we have an elastic pupil, which is like a rubber band, and any pupil expander would work. Whereas the rigid or fibrous pupil is more like a string where you need to tear it. You can choose to use either a strong or bulky pupil expander or Coughlin hooks to do that. Now, we could check the elasticity of the pupil before we start. A very simple way, you just inject BSS through the paracentesis, and if the pupil expands momentarily, you know that the pupil is expansile, and you could get away by just using a pupil expansion device. Whereas, if you do inject with BSS from the side port and the pupil does not budge or just expands minimally, you know that's a rigid pupil, a fibrous band is there, which needs to be torn or stretched by using 2 Coughlin hooks, and only then you will be able to comfortably and safely use a pupil device. So how you wish to tear the rigid or non-elastic pupil is your choice. With 2 Coughlin hooks, you have a controlled tear with a round pupil, and BHEX is a good choice over there because it's a thin device and it occupies less space, allows easy instrument movements. If you want to do it with the pupil expander like a Mulligan ring or the Apex or iRing, these a little poor control and asymmetric tears, and these are bulky devices, so you have less space in the anterior chamber to use your devices. So what matters most is the elasticity of the pupil and not the size. And let me highlight that by a video from Deepak Magur. Now, this is a rigid pupil, a pseudoexfoliation, not an IFIS case. So you stretch the pupil, yet it's not good enough. So go ahead and use a pupil expander. You could use anything, iris hooks, any pupil expander, and it works fine. Now, this is a 5.5 millimeter pupil and works very well for a hard cataract as long as you chop that cataract into very small pieces and you do not stress the device and do not dislodge the device. So mechanical dilatation of the pupil. Pupil stretching is not effective in IFIS, like I said. These are elastic pupil. It could be effective in a rigid pupil, but what prevents there being from an overlying IFIS? That would cause intraop myosis, and then again it becomes ineffective. So these are the devices we have: iris hooks and pupil expansion rings like the Mulligan and the BHEX. So this is a video which is very close to my heart. 2013 in San Francisco, I presented the ASCRS, and ASCRS circulated to worldwide. So this is different grades of IFIS. So this is the grade 1, and this is grade 2, a very classic one. I apologize for the star quality. These are all taken from VHS. This is P2005. And you see, this is so typical. You inject BSS or viscoelastic into the antechamber, and the pupil expands to its full. And as soon as you take off, the flow creates a meiosis. And look at this. I've used iris hooks, yet I couldn't even complete my capsulorhexis without fraying the iris. And every time I went in with the phaco probe or the IOL injector, I had to protect that iris with a side port instrument. The side port always looks bigger because the iris is prolapsing. Actually, it's not that big. And look at that iris. That's so typical, a sail-like iris, a patulous iris. And of course, you have the iris hooks, which is providing you excellent visibility, but I have a frayed iris like a fishing net. Looks very good at the end. What I wanted to emphasize was iris hooks or retractors do not guarantee against iris prolapse, but they do ensure a constant pupil size. Let's see, you would possibly think that I would have a bias towards BHEX and assume that BHEX has a protective effect on IFS. Well, not true. So this is a theoretical. I just had a hint of IFS, so I used a BHEX kind of prophylactically, and yes, lo and behold, I have the iris prolapsing through the side port and the main incision. No device really helps, and well, fortunately, that any device again provides you with a constant pupil size which does not come down on you. And of course, BHEX over here is a huge advantage that you can take it out through the side port, 1 millimeter side port, and you can pull it out. So if you have intraocular myosis, my go-to devices would be either iris hooks or the BHEX pupil expander. It's different from the Mulligan ring because it's uniplanar and it has a lower vertical profile and it bends the iris. It does not snag the incision or the capsulorhexis margin or anything else. Now let's look at this video by Deepak Megur, an intraocular myosis. Now here your pupil has come down on you, you have a capsulorhexis. What do you want to do? You just want to inject viscoelastic under that pupil margin so that you create space and tuck those flanges of BHEX, which are very thin. And every time you engage, you are absolutely sure that you have not engaged the capsulorhexis muscle. As you draw it to the periphery, you have instant confirmation that you have not engaged the capsulorhexis margin. And as you can see, then it's all under your control. Now, some of us do like taking chances without a device in a 4 to 5 millimeter pupil. All you need to ask is yourself is if you have a cataract and a non-dilating pupil in your eyes, would you like the surgeon to take chances? Your answer, I think, would be pretty obvious. So IFS has meiosis and iris prolapse. Iris hooks or pupil expanders just provide a constant pupil size, good visibility for safe phaco. Iris prolapse, no device actually helps, and it depends on the IFS severity. So if you do not have iris prolapse in a given case, do not give any credit to the device. It's purely lower grade IFS. So a favorable device would be one which requires small incisions, has a low vertical profile, and can exit through the side port. Iris hooks and BHEX are well suited for that. Yeah, so and the BHEX can be removed through the side port, like I showed in an earlier video. That's a huge blessing in IFS when you have the iris prolapsing through all your incisions. This is a case of FACS where Ajay Paul shows a wonderful video where the pupil was small to start with, and with a little bit of laser energy, sometimes the pupil does come down. And so it's a 4.1 pupil, not a very favorable situation after you've had a FLACS capsulorhexis. Though the capsulorhexis margins are supposed to be pretty strong now. Well, a BHEX comes to the rescue, a little bit of visco under the pupil margin, and the flanges are tucked one after the other, alternate flanges are tucked one after the other, and then you're back to your comfort zone where you have excellent visibility. So you could use any device, you could use iris hooks also, but then a larger number of incisions, and probably doing a FLACS, you would not be very keen on increasing the number of incisions. So medical management strategy, well, a host of systemic conditions, like I said, and there is no history taking, can never be foolproof. And like I said, preoperative people of 7 millimeter or less could cause IFS, and it could even occur after 1 year after stopping tamsulosin, and it could occur within 3 to 7 days of initiating tamsulosin. Stopping tamsulosin is really of no great value. And you must realize that if you do stop, you could be subjecting the patient to a bigger risk of urinary retention. And remember that women also are often on tamsulosin for UTI. So every disciplined approach is probably what we need, is that we need to keep a stock of pupil expanders or iris hooks in our OR and assume that every eye is a potential IFS candidate. Viscoelastic injection we must use judiciously, and we should distinguish an elastic and a non-elastic pupil. And of course, the choice of pupil device is very individual. Then it depends on the elasticity of the pupil and how you wish to tear a rigid pupil. And I believe a 5.5 expanded pupil is pretty good for any grade of hardness of cataract. I would encourage you to look up the stent tips on phacoemulsification in small people, which is available at eophtha.com. Thank you very much once again, Namrata and AIOS for this opportunity, and thank you for your patient hearing.
Thank you, Subin. It